Well, thank you so much for the invitation. I was running because I don't want to lose any minute of this imaging course. So we all know that if we see this type of image, we are going to have a bad prognosis. And also, if we have other complications as this RPE tear, in this case of neovascular AMD. But in our daily practice, we see other types of lesions more commonly, and we can really classify and have a different prognosis depending on each type of lesion. So thank you so much for the invitation, and I'm going to review first the diagnosis and management of neovascularization in AMD. We all know the classification of AMD based on fluorescein angiography. This was based on 1991, and there are other classifications, more anatomical, based on clinical-pathological correlations set by Dr. Gass in 1998. This was the base for this new classification proposed by Dr. Freund in 2010, classifying lesions in type 1, type 2, and type 3. So I'm not going to really talk about the prevalence of each type of lesion because you all especially know because of your special location between Asia and Europe. So we know that the prevalence is going to be really different depending on the area where we are, but especially for RAP or type 3 lesions and PCV. But it's important to point that if we use fluorescein angiography only, we are to really misdiagnose some of the types of lesions. So we are going to overdiagnose the number of type 1 lesions, and we are going to underdiagnose the number of type 3 lesions. And this is really important. So the use of OCT in order to classify CMV lesions is really important. And also we are misdiagnosing and underdiagnosing the number of combined and mixed lesions. So overviewing each type of lesion, we know that type 1 lesions are characterized by a late staining on FA. So we have an occult pattern. And on OCT, we are going to have a lesion below the RPE. And normally, it's associated with the presence of subretinal fluid. For type 2 lesions, we are going to have a classic pattern on fluorescein angiography, and the lesion on OCT is going to be located above the RPE. And it's going to be associated not with subretinal fluid, but mainly with intraretinal fluid. And look that the RPE is disrupted because the membrane is going to break through Bruch's membrane and RPE in order to arrive to the subretinal space. It's important to point that in some cases with type 2, the lesion is above the RPE, but with treatment with anti-VEGF, we can have a conversion into type 1 lesions. So we describe this conversion in some cases with type 2 lesions, and with treatment we can really have a conversion of type 2 into type 1 neovascularization with a better prognosis. And we can also see this type of conversion with OCT angiography, with a network of vessels getting reduced and really getting an envelopment of the RPE above the neovascular lesion. For type 3 lesions, it's really difficult sometimes to analyze fluorescein angiography, especially if we don't have spectralis devices. And it's going to be really easier to analyze OCT images. We are going to see this funnel shape disposition of the outer retina. So what we have to do is to really scan all the area of the macular area and really look for this funnel shape disposition of the outer retina with association with intraretinal fluid and hyperreflective foci. And it's important to point that the use of OCTA is not that useful to use the ANFAS viewing, but the B scans, and really go through all the B scans and look for these kind of lesions with this column of flow signal. So in summary, we have type 1 lesions below the RP, type 2 lesions above the RP, and type 3 lesions intraretinal. But why it's important, this classification? Well, depending on the type of lesion, in Spain we use a different treatment. We use a pro-renata treatment when we have unilateral type 3 lesions, and we normally use for type 1 and type 2 more a treat and extend protocol. And if we have bilateral involvement, sometimes it's easier to use a treat and extend, although fixed bi-monthly injections is also useful. But it's mainly important to classify the type of lesions because of the risk of macular atrophy is going to be different. So we are going to have a higher risk for macular atrophy with type 2 or type 3 lesions. And I'm going to put this example. This is a type 1 neovascular lesion in the right eye of this 78-year-old female that she has underwent 48 anti-VEGF injections over 7 years of follow-up, and she has developed this area of macular atrophy in the right eye. But look at the fellow eye, the left eye with no intravitreal injections at all. She has developed a large area of geographic atrophy. So sometimes we think that anti-VEGF injections predispose to the development of geographic atrophy, but it's going to really depend on the type of lesion. And this is the follow-up with near-infrared reflectance showing, showing the progression of atrophy outside the area of neovascularization in the right eye. So it's not always dependent on the intravitreal injections. And we are going to see that the left eye progresses over the years with a lot of areas of atrophy that converge into a large area of geographic atrophy. And if we compare, so maybe type 1 are protective for geographic atrophy or macular atrophy. And if we compare these type of lesions with type 3, we know that type 3 lesions are associated with age-related choroidal atrophy, which is described by Dr. Spade as a choroidal thickness less than 125 microns. We are going to see that these type of lesions are going to develop a lot of areas of atrophy, multifocal areas of atrophy, not only in the area of neovascularization, but also outside. So type 3 lesions are going to have a high risk for atrophy. So in summary, type 1 lesions are below the RP and they have preserved RP, so they have a lower risk for atrophy, despite the fact that we treat with anti-VEGF. Type 2 lesions are going to be located above the RP, and the lesion broke through the Brooks membrane and RPE, so they have a higher risk for atrophy. And type 3 lesions are intraretinal, but they are located in between the gap that the RPE and basal laminar lead, and they are associated with age-related choroidal atrophy, which is a high risk for atrophy, so they have the highest risk for atrophy. So no matter where we are, the classification of neovascular lesions with OCT is really useful, and I want to thank you for your attention.